Ay, no. No está bien. No.
Now, testing, yes. And if we go cigarettes, almost every time. Adjusting the mic level. And in addition, there's things all the time about the quality of the sound. Sometimes even lighting, but that was the sound. Having the same one before anyhow, up there. Yeah, I try not to because I'm afraid to sit here and start doing like this. No, just the length of it. And that's what I do. So that's great. I'm trying to it's not just with food. Well, a lot of times you use and sometimes we do it a lot. So anyway, I don't know, right? Overall, it probably is aging. So anyway, looks like good. Thank you, sir. Yeah, on the back and fall. Thank you. These guys are terrific. You saw how fast we got down here to fix this. I'm telling you, this IQ is the most efficient, effective office on this campus. Let me give a little bit more about it. Is that more? I mean, it doesn't aggravate me for me. I want you to know that. I'm really easy to get along with. I get paid whether the thing works or not. It aggravates me that your time that you're paying money for is wasted, and that's why you really need to speak up to the administration. He just indicated that this is an old audio system, and the only way it's going to get revamped, professors can complain all the time, and you know what happens? Nothing. You have no idea how powerful you are. Complain, and it's your money for mom and dad. It's just as important. All right, so any questions? I haven't looked at the scores yet. I'm trying to catch up those of you who had makeups. They're very close to having been, we're all scored with it, and very close to having been put into the system. So be patient, and we'll have this all up and running by the end of the week so that you can see where you stand. I mean, it's real easy math after 3 tests. You can figure out with your extra credit exactly what you need on the final to get a letter grade that you're aspiring to get. You know how to do that, right? Because the numbers and points you need are very clearly articulated on the syllabus, and all you've got to figure out is what you have remaining. I forgot to bring a hard copy of the announcement that I put on this morning. There's another extra credit opportunity with Dr. Alfaro. She does extraordinary research. And add that, another opportunity for 3 points. Okay? You with me? So we move on. This is probably the segment that has the most interesting videos to go through, waiting for video material. I have, just to give you a teaser here, I have a video that connects directly with something that happened in one of our local high schools and was in the newspaper this morning. So I'm going to tell you, because I know not one person in this room reads the newspaper, it's for old people. But in any event, that's where we're moving. I think this particular segment here is a very interesting one. You're going to see a very interesting video connecting with, not sexual dysfunction. There's no skin flicks. Some people have on sexual function, sexual dysfunction, they have these skin flicks. But this is not a sexuality course. This is a sexual psychopathology course. So you're going to see a psychopathological sexual function issue addressed in one of the videos, and then when we get to schizophrenia, you'll probably see a couple videos you'll never forget as examples of how really ugly the disorder of schizophrenia can be when it emerges in young people who, at the time, were in fact quite functional. So that's where we're going. Sexual dysfunctions overview is here. That's right, I have this overview slide. And it's really sexual dysfunction, sexual disorder. There are a lot of people, and you guys have heard this song before. I can tell you there are a lot of people within the sexual function, sexology area who are very disturbed by how much pathologizing is done on sexual function. And you're going to see why when we get to some of the more common presentations of sexual dysfunction in the clinic. The first thing I want to say before I go over this overview is that, and I make this clear to every single class in almost exactly these words, if you're headed to graduate school in a helping profession, and you want to be busy, consider specializing in sexual disorders and sexual dysfunction. There is specialization. If you're interested in pursuing this area, I strongly recommend the quadruple S, Society for the Study of Sexual something or another. Anyhow, it is an academic organization that meets once a year and has a very legit conference about sexuality and some of the emerging issues in sexuality. And embedded in that organization is certification as a sex therapist. And I recommend this for two reasons. Number one, you're all looking for a job, and I'm here to tell you there is an enormous amount of sexual dysfunction in our population. And when I say our population, I mean not the Valley, the entire American population. It is an area where there are few trained, certified professionals capable of dealing effectively with the kinds of things that people bring to the clinic, the mental health clinic, mind you, concerning their sexual function. And we're going to go over those. And I even my graduate students, I say, hang your shingle up. You know what that expression is. You get your certification, hang your shingle up on Monday and Tuesday, they'll be keeping the doors down. If you let especially primary care physicians know that you have specific training in these disorders. The other thing about it, set aside the paraphilia, we're going to talk about that in a different way, sexual dysfunction, for the most part, is one of the most treatable phenomena that occurs in the clinic, whether it be a mental health clinic, medical clinic, counseling clinic, marital therapy clinic. It is extraordinarily treatable, often with a brand of therapy that we call bibliotherapy. I may have mentioned this once before in the course. Do you all remember what bibliotherapy is? hand somebody a book to read, and what they read changes their attitudes about what it is that they're trying to do in the way of achieving happiness in a realm of their life. These are the self-help books that are out there. Many of them are worthless. There are many very good self-help books for sexual dysfunction in males and females, most notably females, and you'll see why when we get to that point in time in this lecture material. So now let's take a look then at these two very different types of sexual dysfunction. The first that I have in the first box here is getting massaged into a different look from DSM-5, but it's not that different that this isn't still applicable. The disorders that we characterize as sexual dysfunction fall into a category of whether or not there is zero potential activity up to whether or not a person gets to a point of sexual gratification and is unable to finish. So you can see this is almost a point from desire through arousal through orgasm that defines the way people are sexually dysfunctional. So we have then disorders of desire, disorders of arousal, orgasmic disorders, and then in a special place that we'll visit very briefly, an area called sexual pain disorders, not uncommon. Then a horse of an entirely different color are called paraphilias. And paraphilias are, let me try to bring this home to the language you're probably used to thinking about. Paraphilias are what you think of as perversions. Perversions is a term dependent on the eye of the beholder, you will find. And you will come to understand, and this is an important, very important concept for you to appreciate starting this area out, and that is there is enormous variability and complexity amongst human beings concerning sexual behavior. And we'll visit that, and we'll take a look at the paraphilias, and you'll even see how across time what used to be regarded as a clear psychopathological phenomenon is now simply seen as a phenomenon which, when occurring, may be off the curve with regard to the population of sexual behaviors, but it will only be addressed as a problem if the person is distressed about that problem. It doesn't even need the blah, blah, blah criteria, whether it affects the person's ability to function on a day-to-day basis at home, at work, or at school. The person only needs to be distressed about the situation or it to be regarded as an active one, mental disorder, along with all of the other active ones that we've visited so far. Okay, so you get these two very different boxes going on here. One has to do with sexual function and dysfunction. The other has to do with unusual, off-the-curve behaviors that distress people and cause them to sometimes pursue mental health, professional help. Okay, I made this point already. Note that dysfunction problems are in the area of the way sex happens in the spectrum of arousal. Either one has no desire, or one does, and if one does, one must achieve arousal, and ultimately the goal is for that arousal to take that person to a state of gratification known as orgasmic experience. So, a couple of things that might show up as test questions waiting to happen. I got to get a lot of those. You're all rallying now, right? So as many points as you can. For this segment, I'll really be throwing them out there. Although I didn't saw a lot. Somebody sent me a reminder of several, and I think I hit every single one of them. So do mark them down. Okay, lifelong or acquired has different prognoses. I mean, this is like, you can figure this out, just logically. Someone's got a lifelong sexual dysfunctional problem, it's going to be much more difficult to treat. Not impossible, but much more difficult to treat than if it was recently acquired, emerging later in life. Generalize the situation. Obviously, if the sexual dysfunctionality is specific to the spouse, but no problem with the girlfriend, that would be situational, wouldn't it? Therefore, to the extent that the sexual dysfunction generalizes across all people who would be potential targets of sexuality, so to speak, then we have a much more difficult problem to deal with. Okay. So let's start with the desire disorder. There are two brands of sexual desire disorder. So you see, we're dealing at the very first level. In a way, you can regard the desire disorders as more serious, because if you don't have desire, none of this other stuff is going to happen. I mean, sexual arousal doesn't occur without desire. So desire is a very critical point of entry, if you will, into the sexual dysfunctional area. What we used to call, or what you will hear medical professionals call libido, a term borrowed from Sigmund Freud, of course, refers to desire. Libido, do you have interest in sex? And if you do, that's the beginning. Now we ask the question, how much interest do you have, and are you able to become aroused? Now, sexual desire disorders, needless to say, occur when the answer to the question, do you have desire, is no. Or if the desire is very significantly inhibited across time under circumstances where it shouldn't be. So we have then hypoactive sexual desire disorder. Persistent, this is right smack out of the diagnostic manual. Persistent or recurrent, deficient or absent sexual fantasies and desire for sexual activity. Formerly known amongst women as frigidity. Far more common in women than in men, and by the way, I'm going to put a footnote here because the SSRIs have as a most frequent so-called side effect decreased libido and sexual performance. All of these that we will be talking about are not sexual disorders that are connected to being on a psychoactive medication or connected to a medical condition like, for example, diabetes, which can have profound effects on sexual function. We are looking at, if you will, the psychogenically produced sexual dysfunctionality. Sexual aversion disorder, persistent recurrent extreme aversion to or avoidance of all or almost all genital sexual contact with sexual partners. That's taken sexual desire to the next aversive level, if you will. And hence, the term is aversiveness. In each case, read this word for word, as with almost all sexual disorders, the disturbance causes marked distress or interpersonal difficulty is not due to a general medical condition, but more than the interpersonal difficulty is the distress, because someone can be sexually dysfunctional without it affecting anybody else, and still satisfy the definition that we're using. So it could have no impact on anyone else, if indeed no one else is involved. So here are some, I have a lot of epidemiological material here, these studies. All these studies have a qualifier on them, a caveat. It is very difficult to be certain when we ask on surveys people in the general population what they do in the bedroom. It is very, very difficult to be certain that we're getting back precisely accurate information. Especially in sexual functioning, there is a tendency to exaggerate or to understate, depending on the nature of the behavior that's being questioned. Moreover, it's very difficult to get funding for this kind of research. In fact, there's a famous part of history in the George Bush Sr. Tenure, where a large epidemiological study was funded to the University of North Carolina. The money was almost in place, and under political pressure, you can guess from whom, Bush pulled the plug on it because 15-year-olds were being asked whether or not and how often they masturbated. Apparently, we don't want to know that. As sexual function and dysfunction develop, I can tell you it is enormously critical that we know the answers to these questions. Masturbation is a highly significant normal developmental phenomenon that connects in a very significant way with sexual adjustment as an adult. Highly significant. And when absent or quote-unquote deficient, you can almost be certain there are problems in either arousal or orgasmic achievement later in life. So you see, it's difficult to do this research. Most of the important research that's been done has been privately funded because the government doesn't want to mess with this stuff. And therefore, that's a long caveat, the figures you will see are best estimates with corrections for bias that we expect to come from the audience we are surveying. All right, 15%, one-third of women reported a lack of interest in sex. Obviously, that's a much more complicated situation than what's described here, right? How many people have seen you? I know you don't watch primetime news, but if you want to see this commercial, you haven't. Watch 5:30 national news on NBC, ABC, or CBS. You're sure to see the newest commercial for testosterone, suggesting that every male over 40 has low testosterone. Yeah, it's lower than what it was when they were 20. But the suggestion is that it is clinically significantly lower, when in fact it's not. And therefore, they are appealing, of course, to the 40-year-old who may be seeing a difference in his performance. And of course, the whole answer, the whole solution to the problem, of course, is that things would be different if the testosterone was still at the level it was at 20. The 40-year-old has more testosterone than he needs for very active sex life. What they don't say is most 40-year-olds have been married 10 years minimally and have been having sex with the same woman 500 to 1,000 times. Nonetheless, that couple, and this is very much connected to what it is we're addressing here, unless that couple has addressed the need to constantly redo, re-articulate, re-communicate their sexual interactive successes, there's going to be trouble. And that's obviously why there are so many extramarital incidences amongst males and females under those circumstances. Okay, so point is, yes, there's a whole lot of people saying, I don't have much desire. A lot of it may well have to do with the relationship, stagnancy, if you will, of the relationship that has been allowed to occur in that relationship. You'll see that communication, very open communication between two people is often the absolute 90% of the solution to sexual dysfunctional issues brought to the attention of clinicians. Okay, we also have this little problem here. Little agreement among clinicians as to what constitutes low sexual desire. There's no agreement what constitutes normal sexual desire. Once again, we have this Gaussian normal curve. And how far off the curve determines whether or not one might regard it as low sexual desire, but only if the person is distressed by that. A nun will tell you, if she's in her 50s, that she hasn't felt sexual desire for years, if not decades. Shall we diagnose her with sexual desire disorder? Jesus told us she doesn't have any. Well, I'll throw this in now and I'll come back to it later. Hey, maybe when we come. I think this is a test question waiting to happen. But you don't need to take notes on this. You already know it. The longer a woman goes without sex, the less desire. All other things being equal. The longer a man goes without sex, I don't even have to finish. So already we see two areas where there's something very different going on by gender. All right? So, okay. We have no idea what constitutes normal. You make the call. If you're the clinician and you are certified and well articulated well trained in sexuality, sexology, then you should have no difficulty determining whether or not this is significant enough to intervene upon. So leave the nuns alone. Hyperactive sexual desire, more common in women, connecting to what it is that I just said about that. Lifelong sexual aversion is more common in men, and I don't know why. It's a very interesting, it could be perhaps that childhood sexual abuse in some cases has a more devastating long-term effect on men when it occurs than on women, but that's only a guess, and it could very well be completely wrong. Acquired sexual aversion is more common in women. And that is easy to explain because women are more likely to be victims of sexual assault or sexual abuse than men, probably 3 times more likely, as a matter of fact. And as I pointed out earlier, acquired versus lifelong is associated with different diagnoses where acquired is a better situation to be in. Okay, so that's desire. If I hit a significant point with regard to desire, I think so. Assuming there is sexual desire, someone could be coming to the clinic and saying, I have desire, but I have an arousal issue. And these are far more common in the clinics than issues concerning desire. So let's look at the 3 versions of sexual arousal disorder. Female sexual arousal disorder, right smack out of the diagnostic manual. Persistent and or recurrent inability to attain or to maintain until completion of the sexual activity adequate lubrication / swelling response to sexual excitement. This used to be called frigidity as well. These old terms were very non-specific. Any sexual desire, arousal, or orgasmic disorder in women was called frigidity. And any sexual desire, arousal, or orgasmic difficulty in a man was called impotence. Throw those terms out, you won't see them anymore. Yes? When you have sexual dysfunction at any level, historically it's been called frigidity in women, impotence in men. Those are no longer terms having any clinical, medical, psychological meaning. These are the terms to describe the nature of the problem, and they have to do with ascending from a state of desire through arousal to orgasm. Okay? So very specific definition. Now, let's look at a disorder that is still getting a lot of attention. And I saw an article I get table of contents from several journals, an article only yesterday addressing persistent sexual arousal disorders, seen only in females. And these relatively rare occurrences are connected with a persistent state of arousal. The article I saw yesterday had to do with the tissue surrounding the clitoris, and there's some suggestion that there may be some innervative differences in these women, or differences in the swelling of that tissue around the clitoris. And I think what is hard to understand is that this is indeed a disorder causing a great deal of distress in any woman experiencing. So despite even experiencing multiple orgasms, the person is still, and this is the only word I can find to describe what you see in the clinic, annoyed by the persistence of the state of arousal. So this becomes almost an aversive state of affairs. And again, probably quite rare. Male, there is no such thing as sexual arousal disorder that I've heard of in males. In fact, that's the norm, I believe. It wouldn't be a disorder. You know that I'm going to wake you up, the best test for whether or not a male is functioning or has the ability for sexual arousal is pulse. Okay, now that you're back awake, now that you're awake again, male erectile disorder. Persistent, recurrent inability to attain or maintain adequate erection until completion of the sexual activity, formerly impotence. The mechanisms, interestingly enough, are the same with regard to the autonomic innervation of sexual response in males and females. And I should mention here, because it connects with a very important area that we visited generically earlier in the course, and that has to do with the autonomic nervous system. Remember the fight or flight response? Fight or flight, sympathetic activation of the autonomic nervous system. You get all of these things going on: the blood pressure, the heart rate, the sweating response, pupil dilation, etc. That is also what occurs, if you will remember, in anxiety. Remember how we distinguish fear and anxiety? Anxiety being that same autonomic, sympathetically mediated response to a non-threatening stimulus. Sexual arousal in the male and female is a parasympathetically mediated response. What do you remember about the autonomic nervous system? The sympathetic and parasympathetic divisions work like this. When one is active, the other one is inhibited. So, if you're following the logic here, if someone is experiencing anxiety in the presence of a sexually arousing stimulus, and that anxiety is high, as it can be in a male, for example, who may have issues about performance, anxiety connected to the perception of performance, then that sympathetically driven response is going to inhibit the very thing he is attempting to achieve. Moreover, an anxious, fearful woman is going to find it more difficult to achieve sexual arousal in the presence of anxiety. They are reciprocally inhibited. Therefore, when anxiety is at the core of the problem of sexual arousal, straightforward psychological, psychotherapeutic interventions, not the least of which is systematic desensitization. Remember that technique? Using relaxation to decrease sympathetic autonomic activity so that the parasympathetically mediated events can occur. Very, very important stuff. Always look for anxiety-connected issues in sexual arousal difficulties because of this autonomic phenomenon in which this necessary parasympathetic functioning is being inhibited by the sympathetically mediated activity associated with anxiety. Does this make sense to you? It's really very straightforward if you think about it. Okay. Considerations, some epidemiology. I will probably have to wind down. We wasted 15 minutes getting this room ready, but anyhow. More epidemiological statistics. 1/3 of women surveyed who describe themselves as happily married describe difficulties in maintaining sexual excitement. We'll wind this down with the following clarification of a common misconception about women. If you watch these biology-driven learning channel programs on sexuality, you will think that the only thing necessary for a woman to be in a receptive state is she's right around the ovulatory part of her cycle. Well, the fact is, survey answers to questions related to sexual arousal seem to indicate something very different. Now, it is not that the hormone dependency isn't stronger in the female. We're going to find out. The whole package around sexual arousal is enormously complex when compared to males. Males are, speaking for the gender, thankfully, very, very simple. Sexual stimulus, sexual arousal. For a female, it is far more complex than that. It starts with, if we look at the biological piece of this, some degree of hormone dependence on, not necessarily total dependence, but a more likely receptivity during certain phases of the menstrual cycle. The problem is, as you can see here, A, B, and C, predicting when is what gets very complex. So while you would think it's around ovulation, it may not be. Survey answers to those questions reveal that it varies significantly from woman to woman, and indeed, it would be in the best interest of her male partner to have a good idea when that is for her, if it is for her, with regard to looking for the right times in the right places. Okay, so we're also already that to put this last bullet to rest here, is a significantly more complex phenomenon for women than it is for men. And I will start next time with this very interesting study. I don't know if I have this study online. I think I don't. About sexual reactivity when we study it in the laboratory. There are actually scientists who take sex to the laboratory. We'll look at some of their data and find out some really interesting things about the facts concerning sexual desire and arousal when we get back together on Friday. Thank you for your tolerance of the frustration we have with this system here, but I think help is on the way. Now, those of you who are looking for answers to questions, here I am.